Hello and welcome. Today we're taking a deep clinical dive into Cytomegalovirus retinitis. This is a particularly aggressive form of acute retinal necrosis, a necrotizing infection that can, and often does, lead to blindness with frightening speed. We're going to explore exactly how this virus wages war on the retina, how we can fight back, and why it's becoming an even more pressing concern in modern medicine.
Okay, so here's our game plan. We'll start by defining the disease itself. Then we'll walk through diagnosis, antiviral treatments, and the bigger public health picture. After that, we'll look at the very serious complications and wrap it all up with a quick clinical review. Let's dive in.
So, first things first, let's really establish the nature of this threat. When we diagnose this condition, what are we truly up against? So what exactly is acute retinal necrosis? Honestly, the name tells you pretty much everything you need to know. It's a severe necrotizing inflammation that literally eats away at retinal tissue, which results in profound and all too often permanent vision loss. Now, while a few viruses can cause this, we're focusing on a major player, Cytomegalovirus, or CMV. You have to think of it as the ultimate opportunist. It just lies dormant, waiting, and then reactivates during periods of immunosuppression. We see this all the time in organ transplant recipients or patients with really low CD4 counts. When it reactivates, its replication directly kills retinal cells.
This right here is why the differential diagnosis is so incredibly important. A patient comes in with vision loss, and yeah, it could be CMV. But it could also be syphilis, toxoplasmosis, or even something much rarer like Rift Valley fever virus. The clinical presentations can look frustratingly similar, and you simply can't treat effectively if you don't know exactly which enemy you're fighting.
I know it's a bit of dark clinical humor, but it makes a deadly serious point. The list of pathogens that can rob a person of their sight is long and completely unforgiving. That's why getting a fast, accurate diagnosis is, well, it's everything.
Okay, so how do we actually nail down CMV as the specific culprit? The diagnostic pathway is absolutely crucial here.
It all starts with clinical suspicion, right? A patient comes in complaining of floaters or decreased vision. From there, we need a sample. Sometimes we can get what we need from blood, but for a definitive diagnosis in the eye, you often have to go right to the source with a vitreous humor tap. Then comes the real hero of this story, quantitative PCR. It's the undisputed gold standard. It's not just faster and way more sensitive than old-school cultures, it's the quantitative part that's so vital. It lets us track the viral load, which is the only way to really know if our treatment is making a dent.
So once we have that confirmation of CMV, the next move is therapeutic intervention. This is where we bring out the heavy artillery from our antiviral armamentarium.
Our primary weapon for systemic therapy is intravenous ganciclovir. Now, if we run into systemic resistance, or if the macula itself is under direct threat, we can bring in a targeted strike with intravitreal foscarnet, injected right into the eye. Then, for stepping down therapy, or in less severe reactivations, oral valganciclovir is an excellent choice. It's all about picking the right weapon for the specific battle unfolding in the patient's eye.
Now, things get even more complicated in the pediatric population, especially with neonates. A postnatal CMV infection might actually be asymptomatic, but congenital CMV, that is a completely different animal. It can cause devastating neurological damage and permanent hearing loss. This context demands an incredible level of care, including really fine-tuned dose adjustments. For example, a premature neonate with HSV encephalitis is going to need a lower dose of acyclovir than a full-term baby. In these situations, a high index of suspicion and a referral to specialized care are absolutely non-negotiable.
All right, let's zoom out for a second. Beyond treating the individual patient, how should we be thinking about this from a public health standpoint?
Here's a really interesting point. While CMV retinitis itself often isn't on the list of notifiable diseases, a lot of the other conditions in its differential diagnosis are. I'm talking about invasive meningococcal disease, hepatitis, mpox, you name it. This is exactly why getting the diagnosis right isn't just about that one patient, it's a genuine public health imperative. A correct ID can trigger the reporting that's so critical for tracking potential outbreaks and protecting the wider community.
And inside the hospital, we have a really powerful preventative tool. To protect those at-risk patients, like our transplant recipients,
Using leukocyte-reduced blood products is a simple but incredibly effective way to slash the risk of transfusion-transmitted CMV. It's really a cornerstone of modern infection control.
Next up, let's look at the severe consequences. What happens if CMV retinitis isn't caught or if it's managed inadequately? The outcomes, frankly, can be devastating. The complications are really severe, and they tend to fall into three main buckets. Ocularly, the endpoint can be total, irreversible blindness. Systemically, in that immunocompromised host, CMV can cause pneumonia, hepatitis, or colitis. And in congenital cases, the long-term effects are just profound, often leading to severe neurological damage, hearing loss, and major developmental delays.
And this slide really shows the insidious reach of this virus. We tend to think of CMV as a problem for the immunocompromised, but you have to know that, in rare cases, it can trigger severe neurological complications like Guillain-Barré syndrome in immunocompetent people. It's a sobering reminder that this virus's capacity for harm is much broader than we often assume.
Okay, let's wrap this up by consolidating all of this information into the key clinical pearls you absolutely need to have in your back pocket for managing this disease.
So our first key takeaway is all about diagnosis. For detecting CMV, the method we absolutely have to reach for is
Quantitative PCR. It isn't just that it's faster and more sensitive than culture. It's the ability to monitor the viral load in real time that is absolutely critical for knowing if your treatment is having any effect at all.
Second key takeaway, our frontline therapy. The absolute cornerstone of systemic treatment is going to be intravenous ganciclovir, dosed at 5 milligrams per kilogram twice a day. This is the workhorse agent we rely on to suppress viral replication when we're dealing with active CMV retinitis.
And for our final clinical pearl, it's about knowing the typical complications. So when you think congenital CMV, you should be thinking about those devastating neurological and hearing defects. The one complication listed here that just doesn't fit that picture is
Acute glomerulonephritis. That's a classic post-infectious complication of Group A streptococcus, a completely different pathogen from a different kingdom. Knowing these kinds of distinctions is absolutely vital in clinical practice.
And all of this brings us to a really critical, forward-looking question. As our medical therapies advance, especially with immunosuppression and transplantation becoming more common, we are creating a larger and larger population of immunocompromised patients. This means the threat from latent viruses like CMV is only going to grow. It forces us to ask, how must our clinical vigilance, our surveillance, and our preemptive strategies evolve to meet this rising challenge?